excellent set of cases. I want to know the panel's thoughts on not just looking at the cup alone, but pre-op templating and attention to offset. So you showed 3 cases, Bose, where your fracture neck and the others. What about the importance of the horizontal offset? Because very often when we go back and look at our fracture necks, and especially also in the revision scenarios, you see that the lack of horizontal offset is also a problem with dislocation, instability and dislocation. So I just want to know your thoughts and the panel's thoughts on paying attention to the offset in addition to the other parameters. Horizontal offset.
Yeah, okay.
I mean, it's absolutely critical. I mean, I think if you know, in a fracture neck, I would argue you should lengthen a little bit, increase the offset a little bit, you know.
So without lengthening, if we can reestablish the offset.
Yeah, that's critical for achieving stability.
I think in those cases, we'll have to see where they impinge and dislocate. If it is impinging on the cup and dislocating, then offset wouldn't play a role. But if the GT is impinging and dislocating, then it is a question of probably offset not being restored.
No, Arun, that's not the point. The point is, suppose you use a striker system, for example, so you have 132 and a 127. It's better to use a 127 in a fracture neck of femur. You get that more offset in that patient.
The impinging offset will actually reduce.
I think. No. That is dislocated. No, not dislocated. He's talking about, so offset in a fracture neck of femur, a little bit of offset at the cost of lengthening them, a little bit of LLD. Is very acceptable because we don't want dislocation.
So we have a papers that increased offset will actually increase the impingement free range, that's number 1, and 2, it will take care of the laxity in the tissue. So instead of increasing the vertical length and making the leg longer, you increase it horizontally. So TC fracture neck femur, we always.
If you want to do that, increase only the offset, you need a different neck shaft angle. That's what I'm coming to. But if you don't use a different neck shaft angle and you think you're increasing the offset, you're increasing the length also, and that's the point.
Yeah. So the length and offset combined will increase actually, but
not if you change the neck shaft angle.
Yeah. Okay. But having said that, as he says, the tissues are very lax in fracture neck femur. They're elderly group of people, so tissue tension is very important. That's why the horizontal offset as well is important.
Absolutely.
So Vijay, when do you change the horizontal offset alone, and when do you change both vertical and horizontal? You have a choice to increase to one head size, one neck length more. Instead of 0, you can use a +5, or you can use a high offset step. So, how do you choose?
So, increasing the length will definitely increase both vertical and horizontal offset. So, when you change the offset, because you have the offset trials, it doesn't add to the vertical length, or it adds very minimally to the vertical. So, that's by templating. So, that's why even
you're templated for a normal hip. Now
yes.
The hip is, neck of femur, it's lax. You want to
correct. So that's why. So if you go back and template on the normal side, also it's on the high offset.
What you're talking applies for a arthritic hip.
No. I'm talking about specifically fracture neck and revision situations. So fracture neck or femur, especially when the soft tissue tension is less, or if you think it's or if
it doesn't matter. You can use whatever trial, and you want to get stability with that. You
exactly.
Want to take care of whatever works. Whether you want to put increase
horizontal offset, increase soft tissue tension.
The point is, when you do your trials, you put your offset in. You want to, number 1, feel the anterior capsule, make sure it's not too tight. You want to make sure the leg can rotate externally, right? And make sure the IT band is not, too tight.
That's right.
If you can maximize your offset and achieve external rotation, then that's what I would go with.
And you don't want to, after fracture neck of femur, you don't want the limb to be extending 30 degrees. That means you don't have offset in that. You want to be within 10 degrees of.
In fact, during the trial situation, I trial with the standard neck. Go ahead, take it through the whole range of movement. If I had not, then trial with a high offset as well. So then you can assess the stability intra-op and then decide what is best.
Absolutely, point well taken. Yeah.
No, that is too confusing. My offset is decided by pre-op templating. If a opposite hip has a high offset,
even
I use a high offset step.
Even a neck of femur.
Yeah, in a normal hip, I lengthen. That's simple. You use a bigger head, bigger neck length. You're lengthening and increasing.
Point well taken.
That's a very simple technique. You are confusing now with the arthritic hip.
Is it fair to say that the stability comes first and the other two, like offset length?
No. In a high risk situation. So if a patient who comes just the arthritic hip and comes and say I want equal limb lengths, I certainly don't want to do in everybody. Now in a revision case, for example, stability comes first. There's no question about that. In a fracture neck of femur, all at risk situations or dislocation, stability comes first. But for a standard patient, both are important. Stability is also important. LLD is very important. No question about that.
I also think that there is a risk for dislocation in a fracture neck femur if you put the components in correctly, right? I mean, that case member had 5 degrees of retroversion, right? But if you put components, they still have a risk for dislocation because their soft tissues are lax. But those cases generally will, resolve with non-operative treatment because your components are in the right. So, there's that problem. Was not going to solve itself because the components were malpositioned.
Yep. Yes, sir.
Vijay, probably it is fair to give some consensus opinion regarding fracture neck femur. 10 years back, Ranawat also came out on a couple of things. Number one, anterolateral approach. Number two, cup slightly horizontal and anteversion in a female, combined anteversion 45, male maybe 30-35. Number two. Number three, posterior lip liner. Number four, larger head and high offset, or you lateralize the acetabular or whatever, and posterior capsule. If you are doing a posterior, repair of the posterior capsule structure. And today we have an implant which does not change the high offset, does not change the leg. So it is a middle offset, which is already in the market.
Yeah, so all points well summarized, Sir Pachure. Yes, mic 4, please.
Sir, question for the panel. Suppose in the intraoperative picture, when you are putting a stem, it comes between 12 and 13. There is a confusion when to put 12 because 12 is loose and 13 is not going fully. So what is the take-home message for the new surgeons or the young surgeons how to manage it?
You don't use 12, you prepare 13 more and then put your 13 inside. It's very simple, yeah.
To avoid intraoperative fractures. So what are the tips?
If the bone is osteoporotic, go for a cemented 12.
Yeah, you should never come out of the OR unhappy. And that's one of the things, So even if you want to spend extra time, you must, and then you can sleep well at night.
Generally, you take the broaches out, you rebroach, you continue to prepare. You may want to put a prophylactic cable on that situation. And you have to figure out where, is the stem being held up? Is it being held distally? Because it's, then ream distally. If it's being held up proximally, sometimes you can take a larger broach and just gently, broach with the 14, so you can get the 13 down. But you don't want to put a undersized stem in. That's the wrong answer. It sounds like you got to get the 13 in. And other times it's you got to switch systems, right? Whether it's going to cement or going to a different morphology of your stem shape to get the better fit. Those are the things. So not every stem will fit in every femur.
Yeah, absolutely. Yeah. So all that Amar said very important. And we encounter sclerotic bones very commonly, and sometimes you just need to have a high-speed burr proximally, and then burr it, and then you need to get your stem inside. So you must look for both axial and rotational stability in every unsymmetrical stem that you do, and you must not come out of the OR if we didn't demonstrate axial and rotational stability of the stem.
And so second question is for the teriparatide plan, post-operative for TKR and THR. So can we start on the next day? Or we should wait for a week or so?
So when do you start teriparatide?
So you need to check the patient's vitamin D level. If it is low, you cannot start it straight away. So we correct the vitamin D. It may take from 4 weeks to 6 weeks. After that, you start it. You need to assess your PTH level and make sure it is not secondary hyperparathyroidism situation where you should not be giving as a contraindication.
Thank you.
Your bone biochemistry must do before you start them. Bone biochemistry must be normal. Calcium phosphorus, alkaline phosphorus must be normal before you go ahead. Yeah.
In elective cases, even I don't mind starting it before the surgery.
Sorry, which patients?
In elective cases of TKR and
yeah,
you can start before surgery.
That's what Professor Malhotra said. You need to optimize them metabolically. Very important. That's the key thing. So any other? Yes, Parag.
Question for all the panelists, and it's a little bit related to the knee. So how much do you think this uncemented knee will become popular in India? Because right now it's not easily available, or in fact not available at all. Like for the hip, Amar was saying, most of the hip surgeons have moved to uncemented hips. But what do you think will happen with the knees? Is it going to be a good idea?
So we will take it to the entire panel, yeah, starting from Narayan, yeah.
I'm also as much as confused as you are, so no answer.
As long as I have not tried it, I would say it's even not fair to say it, but I think we are happy with the cemented in India.
I think there's a time is going to come when you'll have an uncemented knees, and when you have younger patients, and when you're doing a lot of CR knees, uncemented. I have done a couple of them up to pace a couple of years back, and there's good, the femoral component I'm talking about.
The literature is in favor of...
Before Harish says the micropod knee, we are going to have unsymmetric components from next month onwards, yeah. Just to give you a perspective that not available in India, it's going to be very soon available in India. Yeah.
The
All makes are going to come, yeah. So this year we'll have all the.
And the cost will also come down, I'm sure about it.
But the question is, if company which you use is not going to give uncemented, are you willing to change a different design of a knee just because it is uncemented? Or would you wait for your company, which you are comfortable with, to give that design in 1, 2, 3, 4 years time? So if you ask me, I am comfortable with X design and I'm happy, get good results. I would not switch to another type of a design just to get an uncemented. But if I get uncemented in the same design, I probably would like to use it. And if I find it is giving a better outcome, lesser pain, longer survival, it becomes very common, popular.
Right.
But it's little too early to comment on that. We have to, it has to be available with at least 3-4 different companies, and at least 10% of us should have used it for a couple of years.
Okay, Rajshekhar.
The bone quality is only the determinant for that whether it is uncemented.
No, your prediction. What's your prediction regarding uncemented knees in India? That's the thing.
That's indicated good bone.
In a lot of patients we have measured.
So you think it won't come? Okay, fair enough. Arun?
I think maybe if it comes out well, I don't anticipate using it for maybe more than 25% of cases, I think.
Fair enough. Then
Because of osteoporosis worry? Yes. The bone quality?
It's going to come. I'm happy to use it. It's going to be the future. It may not be 100%. At least there are a good amount of patients whom it will be suitable.
Yeah, and Amar.
It's definitely coming.
Definitely
and
coming.
you're definitely going to use it. And it's going to, like we said, it's going to start off slowly. It's going to be in younger, active males with better bone quality, and then you'll start to push the envelope a little bit, and you'll realize cement isn't the worst thing in the world. But to Harish's point, if you want to get your company to pay more attention to you, put another knee in for a couple of times. And then
Absolutely, yeah. That's probably the best message today. Okay. Now, coming to hips for just Parag, because just as you said, the poly was always, or the bearing was always thought to be the weakest link in the chain of biomaterials. And therefore, whether it's cemented or uncemented stem was the same. Even now, people say it's the same. But now, ceramic uncrossing poly has been such a boon that that's not the weakest link anymore. I was trying to address some other is going to be the weakest. It's going to be the stem. And now I say the non-cemented stem on the THR is going to be far superior, because cemented stem do well, but not, but this one is osseointegrated and probably would outlast cemented, because that's going to be the weakest link today. So like that, once we move from good bearings in TKR also, we look at the next one. How can longevity be? And that could be a nonsense. So I predict, like Amar, it's coming in India, folks. At 2-3 years, we'll all be doing uncemented. Yeah, that's my prediction.
So you'll be happy to use it once it comes, and you're
absolutely, yeah, absolutely.
But on the same note, but if the bone quality, Elana, is osteoporotic, do you think by giving some medication we can improve the bone quality so that it's suitable for uncemented knee? Do you think a year of teriparatide or whatever?
Please do come to my friend, please.
Yeah. So do you think it's, because after 55, post-menopausal, after 50, its bone quality is the issue. So if you're going to get uncemented, is there any way an endocrinologist can help us?
I think if you have treated osteoporosis, so usually the spine goes up very rapidly with teriparatide. You oftentimes see the lower limb go up more so in the second year of teriparatide. But I think if you have treated osteoporosis with either an anabolic or one of the anti-resorptives, you're in a much better place from a bone perspective, and in those cases.
So the duration would be how long?
So in the States, because everything is done so quickly, the way that we frame it is as long as they're on something. So, but the AOA on the bone has asked for a 3-month period but then you continue on the osteoanabolic.
And they can be on it after doing the knee as well.
Absolutely, without disruption.
Thanks very much for the clarification. Yes.
Sir, taking the point forward from the slide you showed about the larger heads being available for smaller cups. So tomorrow, once these companies do make those heads available, if I've put in a 48 cup in, say, a 30-year-old guy, should I be opting for a 32 or 36 head or giving them more poly to wear out? What is the better trade-off?
That's a great question. And I struggle with that myself. If I have a really young person and I have a borderline cup size where I can get in a larger head, if they're like under 45, I've tended to go for a 32 head and maximize my polyethylene thickness, because I've paid attention to all my component positioning, right, and the construct. So I'm I'm more confident of that. I'd rather have less volumetric wear, et cetera, over the course of a 30, 40-year situation. So yeah, I mean, I think you have to, you know, if the person had Ehlers Danlos and something else, then I would probably go for the bigger head, right? So you have to weigh all those factors.
Yeah, I think I'll take it on a case-by-case basis. But the present one, for example, the X3 poly that we have with 36 heads seems to have very good data to support that you can use it in younger patients. But DePuy, I think, is going to much larger heads. Most companies are using going to 40 heads, and that, of course, we need to wait for data to come. But 36 heads in the current generation of poly seems to work extremely well. So, especially our patients want to sit on the floor, etc. So I wouldn't hesitate using it in an young patient.
The problem is, you know, a lot of these companies will come out with a new cup that can take a thinner liner so you get a bigger head, but then they don't have a constrained liner for that cup, right? So there's trade-offs to everything. So, you know, if I'm doing an elderly person, I'd rather put in a 32 head knowing I have a constrained liner if that person becomes a late dislocator or something.
So that's fantastic. So with that note, we close the session.